topic of discussion is rehabilitation and optimization. To chair this session, I invite Dr. Avnish Bhardwaj, Emeritus Professor of Department of Anesthesiology, former Professor and HOD of Department of Anesthesiology at Mahatma Gandhi Medical College, Jaipur. Along with him, I also welcome Dr. Priyamvada Gupta, Professor and Head of the Department of Critical Care Medicine at Mahatma Gandhi Medical College, Jaipur. And to present this session, I welcome Dr. Gaurav, Professor and Head of Cardiac Anesthesiology Department of at Mahatma Gandhi Medical College.
Thank you, sir, for giving me this opportunity to give insights on optimization and rehabilitation.
While Dr. Gaurav is starting, I must add that he is the backbone of our liver transplant program and also all the complicated GI surgical procedures that we do.
In previous sessions, we understand how even a minor complication can lead to negative outcome. Uh, so how can we reduce or predict complication is going to happen? So this is by the optimization. Optimization is doing adjustment for the judicious use of available resources. To reduce complication rate, we all do optimization in our patients long way back and mostly focused on control of comorbidities, blood sugar levels, blood cycles, and other biochemical values. Uh, but as the more and more complicated patients are coming to us and for more complicated surgeries, we do need a little more thing, not only using optimization, we want to improving overall status of the patient before going for the surgery, and that is what it is called rehabilitation. So basically, rehabilitation is preparing individuals to weather the storm of their surgical stress and to avoid overcome complications. Classically, it is defined as any preemptive intervention intended pre-operatively to strengthen patient physical, medical, nutrition, and mental condition, aiming towards increased patient capacity for resisting surgical trauma and facilitate post-operative return to pre-operative condition as soon as possible. It is an integrated services require several multimodal interventions and results say literature says that it can reduce complication rate up to half of the previous value. Basically, rehabilitation is an extension of ERAS protocol. It's a first component for the ERAS protocol, and a little bit insights of how surgical stress has happened, as Raju sir has already pointed out. Whatever stress, whether it's a surgical one or psychological one in the preoperative area, it stimulates the hypothalamic pituitary axis and lots of inflammatory and hormonal neurohormonal transmitters are released, which causes release of lots of hormones and interleukins, interferons, TNF alpha, growth hormone, thyroxine. All of them causes increase in metabolic rates, which requires a lot of energy to take over it, and all the energy stores get depleted in form of glycolysis, proteinolysis, lipolysis, etc., which increases inflammatory response to the body and also increase blood sugar levels. So let's see what literature says regarding the preoperative aerobic exercises taken in the pre-elective area and the cavity surgery. This aerobic exercises giving a precondition to treat the stress responses and improve functional capacity to help withstand the stress of surgery. It includes dietary modification, relaxation strategies, sleep hygiene, and exercise prescription. Rehabilitation reduces in this review article, they concluded that length of stay decrease of complication accelerate return to preoperative function area quickly. Another type of rehabilitation is nutritional enhanced recovery rehabilitation and immunonutrition drinks 3 times a day for 5 days previous to the surgery. Carbohydrate loaded drink night prior to surgery and preoperative multi species probiotics with 10 to 15 million daily of probiotics can reduce complication up to 49% and hospital stay reduces by 14%. Direct hospital cost reduces by 60% and time to return to normal bowel function is quickly in these patients. So basically, rehabilitation has a 4 pillar program. It's a physical component where the patient endurance is increased. Medical optimization, we all do this. Nutrition support in selected patients, while the mental psychological preparation and education for the lifestyle modification training programs are also there. The fifth pillar of patient education and post-operative lifestyle modification has been added recently in this case. I would like to uh, explain this graph here. This is the minimal physiological threshold activity level, which is seen here, and this is the resting aerobic capacity margin. When the patient in a preoperative area is at the level of A, the only result is this much, while with the prehabilitation, it has been seen that the result is increased. So what happened is, this is the line of dependency. If the patient, a normal patient coming to the surgery, this is the independent phase. Suddenly, after the surgery, this goes to dependency level for a short period of time. And when gradually recovery occurs and the patient comes to return back to its normal independency level at this point of time. Work forwards, if some complication occurs, the dependency period goes down and it takes longer time to recover, but still the even later period also patient remains dependent one. While with the pre-rehabilitation, what we do is we increase the functional status of the patient up to this limits. So in the early postoperative period, the recovery during the early recovery is quite early, and the dependency part is only this much, and even the patient from the baseline also in the postoperative period, patient's functional capacity is increased. Even in this case, if some complication happens, patient can have dependency period little bit longer than the previous one, but still from the previous patients, the dependency period is lesser one. So how we go for this rehabilitation program? So this is a tailored approach, not an algorithm one. Every patient is different with different comorbidities and different physiques. So we can't make a tailor. We can't make a statement for all. So this is a first to optimize the patient in according to his condition also, and do not push too much or do not delay the surgery too much, so the disease can increase up to a certain limit. Initially, what we do is physical activity is score where the respiratory function increased by the spirometry cardiac function. We can do the patient can walk around 2 flights of the stair, can go up to the 4 max, or those who are not 6-minute walk test to assess whether how much the patient is doing muscle strength and mobility during this, and also training about the pain tolerance. But again, this is to be done in a vigilant manner. Everyone has different capacity and should not be put into a risk. So, ball getting scale of perceived exertion was used initially, which was 6 to 20 scale um, uh, assessment, has been now refined into 1 to 10 scale. And with the assessment of patient's activity score, we can see in preoperative area how the patient is improving with our training or rehabilitation programs in terms of physical activity. Again, patients have different type of comorbidities and so many comorbidities in one way, in one patient. So to compile it, it's a very difficult task. So there is a Charlson morbidity score where you can quantify amount of risk where the patient is on with different comorbidities, and there's a scale given, and more than 8 score is supposed to be these patients are ending up to more complication in the post-operative period. So during the pre-operative period, how much we can optimize it, so we can also have to record it. Nutritional rehabilitation is required in patients where most likely in oncosurgeries, where hypex surgeries, where patients are not taking much of nutrition previously and depleted one. Weight loss of more than 10% in last 6 months, body mass index of 18, less than 18.5, and serum albumin of less than 3 are the major risk factor, and these patients require active nutritional rehabilitation in terms of replacements. Again, Sir has already tell that anxiety is one of the major factor for the stress response. So there is a assessment for how much patient is anxious about the surgery, about the anesthesia, post-operative recovery and post-operative complication pattern. So there is again one score, Amsterdam anxiety score, what we are using in our patients to assess. And all these scores are given in a form of a booklet to the patient as a patient education tool to the patient. And this is a prototype of patient information booklet what we use in our institute. This has a pictorial simple diagrams in patient's language and also have a table to have with them. Patient has to bring this booklet at every point of time, at least 4 visits at the time of first surgical visit, second at the time of PAC, at the time of prior to day of surgery, and at the time of uh, patient taking into the OT period, so we can assess how the patient is improving and it is a written form. There are certain challenges for this pre-op program. Though we already are overworked, overburdened, so this is a time-consuming one. It requires a lot of more things. Another thing is now we have this now we have AI-based mobile applications of rehab. It's a new thing to come upon. At home, patient can contact everyone, make a community guide, take a guidance for a few weeks without again coming to the hospital under vigilance and supervised manner. This is a uh, this is the prototype how this works, and thank you very much.
Thanks, Dr. Goyal. Please come. Dr. Thanks, Dr. Goyal, for your comprehensive coverage of this important area of perioperative medicine in a short period of time. Before I set it open, I would like to uh, set the ball rolling by asking you one thing. Please be seated here. Uh, Now, this is agreed that prehabilitation focuses on prevention, early intervention, optimization, and personalized medicine. And this definitely helps improve the quality of life, long term survival, outcomes, and also reduces the healthcare cost to the institution and to the government. Uh, Prehabilitation is more useful in long prolonged surgeries and chronic diseases. So this is a general concept which everyone agrees. What are your comments regarding rehabilitation and optimization in oncosurgical patients? You have an extensive experience in oncosurgery. So on one hand, in this part of the country, patients with oncological cancers, they present late. They present very late and are not well preserved. On the other hand, they undergo prolonged surgery and we focus on optimization, and there are limitations imposed by the beneficiaries of the government schemes and the risk of progression of the disease. So, what kind of a policy do you suggest here?
Oh, sir, actually, we want to have this prehabilitation program clinics in our every centers, and this is a need of a time, right? Our hospitals are overworked and overburdened, and we can't overburden surgeons or anesthesiologists on this. So I want what my suggestion is, there should be a dedicated center, yeah, dedicated centers from there to who can previously look at the patients, compile all the data, and make them fit for surgery. So there should not be any, as sir said, cancellations of surgery or last time postponement of the surgery in terms of optimization in that order.
Well, now, uh, can we have few questions, sir? So, it's open for question. The house is open for questions, please.
So we have in PGI, we did one project, and we have involved the physiotherapy and the dietitian from the PGI and our resident family. So what we are doing, we have developed on that on WhatsApp, everybody puts their exercises and posts in the WhatsApp. So because it's said to be very meticulously supervised. Suppose you tell the patient,
Yes.
go and walk for 6
Yes,
meters.
yes,
He might not be doing.
Yes,
So
yes.
regularly, every day,
yes,
they are putting their WhatsApp exercising,
yes,
whatever they are doing on the WhatsApp, and our registrar then calls them that these are
Yes.
the mistakes you are doing.
Yes.
You have to do like that.
yes,
Certain people get motivated because of the other people doing the same thing. And
yes.
in the same group, the thing is being put. So that is the way I think we can make
Yes.
it better.
So even smartwatches are automatically take up your physical exertion.
Patient.
Yes. So this is an app-based one. So all the patient motivate each other. They can even talk to. Can make their own community in that way, forum like that, discussion, a social media type of a thing. This is what the plan is.
Sir, what I may like to add is, besides whatever academics we are studying, whatever scales we are using, we should always give a personal touch to the patient. We should be empathetic to the patient, and we should give him or her the assurance that he'll be well, he'll be fine. Because what happens when the patient is on OT table, as already it was discussed. So at that time, we have to take care to respect the dignity of the patient. Besides all preparations, it is very important that patient's dignity is respected. Just keeping your palm on the forehead of the parturient who is come for cesarean section gives her a lot of faith, lot of belief. Okay, everything will be fine for her and to her baby. Nothing will be wrong. So that assurance is very important. Besides, whatever we estimate the risk, yes, correctly, that risk is estimated in terms of the outcomes. What will be the intraoperative and postoperative challenges we'll have to face? That is very important. But giving a personal touch, giving some time to the patient when she comes for the pre-anesthetic checkup is very important. A senior person should talk to the patient so that she has a belief, because she should, most of the people don't know much about anesthesia, especially in India, what I have seen. So they should be given assurance this will be your plan of anesthesia, it is very safe and everything will be fine, don't worry. But you have to take care, like bariatric surgery. It is very important that patient's lifestyle is changed before surgery, because if you are going for a sleeve gastrectomy, it is useless if patient is not taking care of his or her diet and not exercising. Likewise, it is mainly means tailored approach for individual patient. Patient going for a ligament repair, ACL repair of the knee joint. So that patient should be taught the exercises prior to surgery, because in post-op period, patient may not be able to do it properly. So these are some finer points which we should touch.
Dr. Gaurav, in a minute for the young people who are watching this, can you tell that in case of an emergency surgery, how much optimization can be done and what are the specific things which can and should be done?
So psychological support is the first one. First, 50% of our struggle can be taken care of just by talking to the patient for the first 5 minutes, and 5 minutes time everyone has, right? So even if we talk to the patient for the first 5 minutes to reduce his stress, then surgical stress will reduced by 50%.
Metabolic parameter.
Yes, ABGs and that all, we all are doing it. We all, I'm sure everyone is doing all those things regarding that creatinine level or blood sugar levels or blood pressure levels, medication level point of time. Though we can't do physical much, but yes, psychological one we can do what we can do at that time.
So thank you, Dr. Gaur. Do we have more time for more? Thanks, Dr. Gaur, for a nice talk. And thanks, Dr. Kapoor and JSF team for inviting us and giving this opportunity.
That is also optimization. You do ABGs, there is a acidosis, you correct it. That is called optimization.
Other problem and the patient died during the post-op because unknown cardiac disease. I think this is very important to do your surgery and evaluation in the post-op for the cardiac disease is very
Even
important.
everything.
That's why I think our resident just evaluate the patient for the cardiac issue patient have. You may not know it because you already have operated and you have a bad outcome.
So once again, my personal thanks to Dr. Kapoor. This has given me an opportunity to meet my senior and my teacher, Dr. J. Mehta, for after a very, very long time. Thank you so much.